So it's time to open this up. We have a few minutes to engage and address some questions and hopefully move forward on this topic before we close for the day. There is one question that we just received from the audience. And please, if you have any questions, and even to panelists who weren't on the immediate past panel, please feel free to put the questions in the chat box, in the question box, and we'd be happy to address them now since we have a few minutes. Actually, we've caught up. The first question is, given the powerful role of faith and spirituality and mental well-being, how do we best address the perception, either arising out of ignorance or out of a faithist intolerance, that engaging yoga or other forms of mindfulness practice is effectively the quote-unquote devil's work or a gateway into Satan's garden? Who wants to take that one on?
Well, I think it comes down to the conversations. And so we cannot be afraid to have those type of conversations. So we dismantle the devil. That was a lot, what you said, Melissa. But that's the way of thinking when we think about prayer and religion. But that's why I said it has to be in this conversation, because we have our own beliefs, right? And so if we don't address things like religion or don't bring it into the conversation of mental health, we do leave out a population of folks who feel like, well, I don't fit into that anyway. So, hey, I'll believe what I believe, or I believe the things that I've heard over time. And so how do we break that? We talk about it. And we don't necessarily give like this opinion that says this is how I feel. Actually, let's talk about how you feel and how some of that stuff is just a myth. And just because you heard it like all your life doesn't mean that it was right. Doesn't mean that it was wrong either. So let's talk about it. A lot of what is missing is talking about it. Again, we've heard a lot of things about religion and when it comes to mental health and praying things away and what that looks like and what that feels like. But are we actually talking about, like, who told you that? Like, let's have like real conversations about it. I mean, that's the only way we can break that up. I don't know if others have opinions about it, but I feel like we just have to talk about it. It's a conversation that must be had.
That's a great answer. Go ahead.
Oh, sorry. I was saying I totally agree, Kay. Thanks for kicking us off, because that totally threw me off guard. And I think in adding to what Kay is saying, that this is about that cultural perspective. How do you find things that work within people's cultural paradigms? And that's important to recognize as well, that the things that we are saying today that are mainstream may not necessarily fit into someone's cultural paradigm. And we also have to look for things that work for them and work within them, their framework as well.
Yeah, it's about centering the person, meeting them where they're at, and really, really kind of relinquishing some of that control that some of us feel that we must have. Just kind of like what I said earlier before this panel about why can't we allow communities and persons to tell you what they need and to tell you how they need it. I think that it blows my mind in this work, even after being an attending physician and scientist for 15 years, it's just still hasn't changed. The other thing is that unlearning. We do a lot of learning and teaching about how to learn, but we don't teach folks how to unlearn. And that applies to so many things we do in healthcare delivery, medicine, science. We learn these things, and then we have to be more agile and be able to unlearn some of these terribly ingrained, bad, racist, et cetera, discriminatory behaviors and frameworks that we have had ingrained in us and taught to us over years. And so any thoughts on how we teach people how to unlearn?
And I think there's a whole field of de-implementation science, just as there's implementation science. And
there is.
And I'd propose that medicine isn't very good at either. Like we have this idea that someone's going to come give a grand rounds and then suddenly everybody's going to change what they do and do the thing that has been suggested by the grand rounds presenter until the end of time when they've been doing the other thing for 20 years. So I think that being really thoughtful about the implementation piece is really important. And then I think a humbling moment for me early in my career was when I put together some poster handout thing that I thought was just the best thing ever, and people wanted to change it, and I'm like, but no, it's perfect. And then I realized that, you know, no one wants to put the poster that was designed at hospital A on the wall at hospital B. They want to tweak it and modify it and design it. And so I think I love the Inspire method. I think it's brilliant. And thinking about how does that travel to another context that keeps the active ingredients in the part that we really need, but then lets people kind of play around the edges. It's like when you're making cookies, if you mess up the milk and the sugar and the flour and the baking soda, you might run into trouble, but you can add all kinds of chips and other things, and it's still a good cookie. So how do we figure out what are the essential ingredients? And then think about the intellectual property piece of that, because colonialism is all about, you know, we live in a colonial paradigm, which is it's mine, you can't have it unless you pay for it. And we want to recognize the hard work that folks have done. And then we also want things to be able to spread and grow. And so how do we make sure that folks are compensated for their hard work, and then that we're also not clutching to it in a way that doesn't let it spread. So it's tough. But talking about it is the first step.
I think all of these themes are running together from our very first presenter. I know we're at the end of the day now, but on decolonizing our minds, and then respectful care and listening and all of the community and patient-centeredness. It's all really saying the same thing, right? That not all shoes fit, and we need to start where people are at, or it's not going to work. And we need to be respectful about it when we do it. So I love that all the threads are coming together with this unlearning question.
Absolutely. Absolutely. In terms of, there's a question from the audience in terms of concordance of providers, healthcare team members, and patients. Any thoughts on concordance in terms of better outcomes?
So this I always have a knee-jerk reaction when I hear this question. When we talk about racial matching, and the provider has to look like the community. I love us who use the Hippocratic Oath. So I'm a perinatal social worker, and I didn't start off by saying I'm a social worker, and we're bound to ethics. And with the Hippocratic Oath, the first thing is do no harm. So we're all here to improve the human condition. So by seeing the other as the human, it should be the human matching first. So I always say that when people say that we have a pipeline issue and we need everyone to match. At the same time, there's a level of acceptability and comfort that you have when someone looks like you. So there's not a silver bullet solution that we need every provider to match every client, every patient. We need to first start with improving that human's condition, and then think about how we become more well-rounded and representative, so that our providers are not 4% African-American, but that they're 12% African-American, right? So the backgrounds do match and reflect the true population. So I don't know if others have something to say about concordance and discordance.
I'd like to take it one more step, like more practical tips. So, okay, so at the moment, while we absolutely need to storm the gates and improve the number of pathways and opportunities and us folks of color into the healthcare workforce and science workforce, no doubt. But for now, when we can't, when we are in a not matched clinical care situation, do you have any specific advice for how you acknowledge and open the conversation to really center the pregnant and birthing person and acknowledge that there is a difference, or does that need to be done?
Yeah, I think, sorry, Kate, go ahead.
Just try to start to bridge that trust.
Oh, I was going to say that I think you have to understand first the layered history that we experience in this country. And I'm speaking from a perspective of a Black woman, right? So it has to go beyond, I'm going to look at you as another human. I'm just going to, because racism is the air we breathe. It's like going outside and not saying you're not breathing exhaust. It's there. So if you don't understand these layered experiences, if you don't understand these issues when someone walks into your office and just what they're coming with, If you don't have a grasp of that, some of the things that you are going to do, you know, from one human to another human are going to fall short, because this human is affected by just a constrained experience of living in the United States. And you have to understand that before you treat me. So I come from that perspective. Yeah.
I also wanted to add to that about what can be done now. It does go, it's, well, you said it a few times, acknowledge. You have to acknowledge the person that is sitting in front of you, no matter the color of their skin, but we don't. We see what we see first, and then we make all the assumptions before you ever even have that encounter with the client. Meaning, before you even ask them what their name, you walked in a room and you made an assumption. So it's actually that acknowledgement piece that in turn leads to that respect, then leads to the support and care that one needs. It's like, start with acknowledging that this is a person, and that most oftentimes we have something in common with people that we don't even think we look at them and we were like, I don't have nothing in common with them, but you haven't even talked to them. You haven't had a conversation with them. So how do you know that based off an assumption? So it's that piece. It's first seeing the person in front of you, removing your own personal biases, because that's what's stopping it. It's your own personal biases that you are delivering before you even deliver the care. It actually influences your care. So it's starting with the acknowledging piece that this is a human sitting in front of me, and I'm going to listen to what this person has to say, and then make my next move based off of the conversation that I am having with them. But I just come from an open mindset versus, again, it's that unlearning that needs to happen. But how do you unlearn? It's actually by doing. It's undoing the harm. If you don't ever unlearn something, you are not actually doing it. I can tell you and show you how to do it, but then you have to in turn go and do it. And the unlearn process comes in from actually doing. Like, start to implement a lot of what we have offered in these webinars all day, and then tomorrow, start implementing these things into your everyday practices. This is how we change that.
Yeah, it certainly takes a sense of heightened self-awareness, practicing, just like we had to practice a billion times to learn what we did learn over these years. We have to practice to learn to do it better and to do it in a different way. That's human-centered for sure. Dr. McLemore, I think you have some comments to make on this. I know you have deep and wonderful knowledge and experience and insight on this. So if you could please weigh in.
Yeah, I mean, from the early, first of all, thanks to all the panelists for your comments and your insights. I'm very grateful for this panel, because I think perinatal mental health in the fourth trimester are things we don't talk enough about. A lot of people, you know, say it's important, but we don't operationalize it to actually functionally be important. I brought up racial concordance in my initial comments this morning on purpose and for a reason, because I think inherently when we talk about concordance, it sets up two things that I think that make people uncomfortable. Number one is that there is existing harm that's happening now. And so there is this conflation between the fact that we have a discordant workforce where harm is actually occurring. And so from scarcity, we move into this place of, oh my goodness, if we already don't have enough providers, then we have to tolerate bad ones, right? So that's one thing that sort of makes people uncomfortable. But I think the other thing that makes people uncomfortable in the context of concordance is the fact that inherently there are some assumptions that I think are driven in that I'd love to unpack. I think Kay Matthews is absolutely correct, which is one of the reasons why I'm one of her biggest fans, that needs to be a conversation, because inherently some people don't think that community members have capacity to be able to be good or even to be trained as competent care providers. And I just don't think that's true. And then you get people who actually they think we have a pipeline problem. And I can tell you from work that I've done with Carolyn Suffering and really training formerly incarcerated people to become birth doulas, it is quite possible, if you think about birth as a normal physiologic sacred process to be witnessed, that there is a skill set that community members and concordant people have. For me, it's more about the question of what's the work and who's well-trained to do it. And part of well-trained to do it means that when you have cultural relativity, when you have cultural humility when you have people who come from the communities that suffer the greatest burdens. If you really want to center in the margins, and the people closest to a problem have the solutions, and that includes being members of the workforce. So for me, I actually think about concordance very differently. I don't come at it from a mentality where, you know, we want to deny the humanity of people who want to provide care. What we want to do is we want to curate a space to ensure that all the wisdom that's necessary from people with lived experience have opportunity, equity and opportunity to become part of the future workforce. Everybody that we serve should be viewed as potential members of the future healthcare workforce. That's the mentality that I use when I think about concordance.
I love that. And I'm often recruiting people to become lactation consultants, particularly mamas of color that I serve, because the lactation workforce is very, very predominantly white. And I was excited that Kellogg Global Breastfeeding Institute got funding from Kellogg to support several HBCUs to start up lactation consultant training programs. And so that's been, and I'm, whenever I meet someone like, you like breastfeeding, I think, and they, I think I'm a little bit crazy, but I would add that there are a couple of things that I've tried to do to decenter myself and to address the power dynamic in the room when I clearly no lived experience as a person of color walk in to meet a patient. I like to ask, tell me what's going well with you before we get into the visit. What's going well? I will tell you it makes for a much more joyful day to start out with what's going well than to say, what's your chief complaint? And then I'll ask, so when I'm taking care of a complicated inpatient who's been admitted with preeclampsia or whatever, I'll say, gosh, you know, the team's told me about you. Tell me what's your understanding of what's going on. I want to make sure we're on the same page. And that gives me a chance to see what the patient understands and not say a bunch of words at her that either she already knows or she has completely not been informed as what's going on. And I need to give a lot more detail than I might otherwise. And usually I'm deeply impressed with the patient and say, wow, you really get this. You know, you get an A in your AI, in your rotation on OB. And so then that really validates her as understanding what's going on. And then I think I said this in my talk, whenever I make a recommendation to the patient, I say, so based on my experiences as, you know, catching babies, this is what I think might make sense, but you lived in your whole body your whole life. Does this make sense to you? And so again, really validating the patient as an expert in her own body and her own lived experience and acknowledging that so that it isn't, I'm telling you what to do because I'm the doctor and you're the patient. And I think those things are helpful. And sometimes I'll very specifically name it when a patient is, you know, very concerned, and I'll say, I'm sure you've read things in the news about women of color having tough birth outcomes. I want you to know this is what our hospital is doing to try to address this, and these are the steps I'm taking to make sure that you're safe. I don't know if it works or not, but those are some things that I try to do in my own practice that certainly make it more enjoyable to be a doctor, and I hope more empowering to be a patient.
Thank you. Wow. Questions are now piling in. Oh my goodness. The inundation. Well, we have to end. So I am going to ask, we'll try to quickly soundbite these questions. And I'm a part of the U.S. Preventive Services Task Force. So there's a question on the U.S. PSTF recommendation for postpartum depression prevention screening, which prevention interventions, which I was a lead in that. Given that they're covered, what can be done to implement these in maternal health care? Is there a capacity within our current system? Are there tailored interventions available?
Dr. Simon, this question is you all day. I will be a cheerleader for the access programs because collaborative care works and it's a support system for patient and provider by adding psychiatric consults. And one consultation center can really help a whole state. It's a cost savings approach. It works. So I'll just throw collaborative care out there. And Dr. Simon, I know this is really your wheelhouse.
Yeah, collaborative care. It's strong evidence for that. And referral and partnership for as much as possible. But I will say we need more recommendation statements like that push these issues and push interventions to prevent. That recommendation statement in and of itself was innovative in pushing that framing. There is a quick question around considering that is being made evident via research and data analysis that the period of concern is 1 year after birth, how do we push maternal mortality and mental health state policy agendas past 60 days?
Can I jump in again? I'm so proud of my state, Illinois. We do a lot of things wrong, but then we do so many things right. So we just extended Medicaid for 12 months. We'll see how long we have this option. But I saw the governor of Florida said that he's interested in doing the same in their new budget. So we've got other states following suit. By extending Medicare coverage, we at least open a window of an opportunity for people to get care, whether or not they can get into providers, all of the structural barriers that exist. We still have a lot of work to do, but this is a first step in the right direction, especially if half of the births right now are supported by Medicaid, and then we drop them almost immediately after postpartum. We're doing a disservice to our nation.
Yeah, that 1 year is huge, and it needs help right now. We need help in learning how to implement that 1 year, because it's extremely complex. Yeah. It's one thing to get it through. It's complex to get it through and pass that there's up to 1 year Medicaid coverage, but implementing it is going to be massively important and complicated. So that's the next step in our trajectory for Illinois, but I hope other states join in for sure. There's one last little comment about the important role of the partner or some kind of supportive person, not just through pregnancy and birthing, but postpartum for that year. Anyone want to take that?
Yeah, I would just say yes, the partner, and we talked about it before. I think Dr. Allison, you talked about it, is that we need that full village, right? So we're not just talking about, we often look at like a postpartum doula and helping mom, and really we need to have a society that works where mom has an entire village. You can't do this alone. Mom and dad, or mom and partner, whoever that is, they all need support. The whole family needs support. Siblings need support. And traditionally, we would have the society that would work in a way that we would have support for everyone, and we could actually heal during that 3-month period appropriately and be ready to be parents that show up, So I think, and we're seeing postpartum depression amongst partners as well. And that's important to acknowledge that happens with partners as well. And so that's something that definitely needs more attention and research.
And can I add on top of that is that we have to make that also the norm, is that this is an effort amongst us all, anybody in the birthing process, from mom, dad, cousin, aunt, everyone, grandma, everybody is a part of this process. And so it really comes down to normalizing that the care that is needed for women or birthing person does not stop after the delivery. Mm-hmm. This is where we take this next. This is how we change all of this, is the language. It comes down to the language and policy. So both go hand in hand, and that's what we need to make this all different.
Yeah, I would.
Go ahead.
Oh, sorry. I was just going to say that if we're normalizing it, as Kay is saying, then that means that 1 year coverage is Medicaid. It's all insurance. It's not just Medicaid, because as Dr. Allison's presentation showed, is that we're seeing gaps in those people that aren't eligible for Medicaid, and they still don't have proper support. So if we're normalizing this, we're normalizing a lot of just support, paid leave, et cetera, around this process for the whole family.
Absolutely.
The most fundamental thing we do is continue the species. And we've built a society that says you're supposed to have a nuclear family, which is a crazy invention that's like 20 years of history that never actually happened. And we're supposed to have an extended family. We're supposed to have a village. We're supposed to rally around folks when the next generation is born. And that, unfortunately, has been kind of stamped out by American individualism, and we need to bring it back.
And with that, there's also the side of the village on the healthcare team and scientists. It takes a village and policymakers working together, all kinds of healthcare clinicians, not just doctors, not just OB-GYNs, as we know. Midwives are super important, nurses, nurse practitioners, everybody, social workers, pharmacists, everybody. It takes the full team. And so it's the village on all parts. And with that, I really want to thank our session speakers, all the speakers for this amazing day. The presentations and discussions have truly enriched our understanding of the factors that shape maternal health and outcomes, including the social determinants of health, the role of systemic racism and early life events in shaping health trajectories, and the access to quality, consistent quality maternal health care. I also want to thank our audience members who have been with us throughout this entire day, and to those who've provided some great comments and questions. I hope you will all rejoin us tomorrow. And the sessions we have planned will focus on the efforts being undertaken at state and local levels to create conditions for improved maternal health and to reduce maternal mortality and policy issues and research needs. So have a great evening. We'll see you all tomorrow. Thank you.